three now. So today we are going to start with the ovarian tumor, and I made it two lectures of it because the topic is little bigger, and I don't want to cover it in just one lecture. So I have divided into two. And probably, inshallah, tomorrow is the Ramadan, so we'll be having all the other lectures in Ramadan timing. Okay, as you all know that the ovaries has three compartments. One is the surface Mullerian epithelium, which encircle the whole ovary, the epithelium. Then inside that we have germ cells, and then we have sex cord and stroma. So each and every compartment has its own tumor. So today we will be discussing the surface Mullerian epithelial tumors because the majority of the tumors comes in this category. And then we have germ cell and sex cord stromal. We will be discussing it tomorrow. Now, each compartment give rise to a distinct non-neoplastic as well as neoplastic entities. So we'll be starting with the non-neoplastic first, and then we'll come to the neoplastic one. Now, this is ovary, as you see, and it has, as I mentioned, let me on the pointer, laser pointer. So we have three compartments. One is this one, which is the surface epithelium. This is germ cells, and in between germ cells, this is sex cord stroma. And then we have some metastatic tumors which comes from other side, either hematogenous or lymphatic. They come and they lodge inside the ovary. So these are the four main different areas from where the tumor can come or can develop, or they come from other side. The maximum amount of tumor, if you see, 65 to 70%, they are surface epithelial tumors, and uh, majority means if you see about the malignant potential, 90% of the surface epithelial tumor among the whole are malignant. If you're talking about the malignant tumors, 90% actually arise from the surface epithelium one. Now the age which affect the surface epithelium is from 20 plus. So it has been seen that before that years surface epithelial tumor does not arise. So 20 or plus, this is the age for surface epithelial tumor. And the majority of the tumor, the main tumors are serous tumors, mucinous tumors, endometrioid tumor, clear cell tumor, and Brenner's tumor. Then we have germ cell tumors, which overall frequency is from 15 to 20%. And if we talk about malignancy, they are only 3 to 5%. They develop malignancy. Now the age group, they start from zero, means from the childhood till 25 is the best age for that. But yes, it can even come, it can cross that age, even 30, 35. You can see that. And the tumors are teratoma, dysgerminoma, endodermal sinus tumor, or choriocarcinoma. Regarding the sex cord or stromal tumor, they account for only 5 to 10% one. Malignant potential, if you see, it's only 2 to 3%, and they actually involve all ages from childhood to the older ages. So the important tumors are fibroma, granulosa cell theca tumor, or Charcot-Leydig cell tumors. And the last category which we have is a metastatic tumor. Metastasis can be from any part of the body. It could be from GI tract, from breast, from uterus, from anywhere, from brain. It can come and lodge. Lungs, liver can come and lodge in the ovary. And definitely 5% they are metastatic. So all 5% they are malignant. Definitely, if they are malignant, they are metastasizing. Okay. Now, if you classify, it's a WHO classification that each tumor, like serous tumor, mucinous tumor, endometrioid, clear cell transient, they are divided into three groups. One is now in if you talk about the other tumors, they are either benign or they are malignant. But in ovarian, we have kept the third category, which is borderline tumors. So these borderline tumors, they are not totally benign, and they are not even considered as a malignant one. So they are in borderline category. We cannot call them a complete benign tumor, but still we cannot even call them a malignant tumors. So if you see, we have serous tumors, serous benign cyst adenoma, borderline serous tumor, or serous cyst adenocarcinoma. Exactly like that, mucinous tumor, they are benign cyst adenoma, borderline mucinous borderline tumors, or mucinous cyst adenocarcinoma. Exactly. Endometrioid, yes, majority of the endometrioid tumor, they are malignant, endometrioid adenocarcinoma. But some of the borderline or benign, which is really seldomly seen, very rare that you see a benign or borderline, but most of them, they are malignant. Clear cell, again, they are rare tumor. They are benign, borderline, or malignant. Transitional cell tumors, they are called Brenner's tumors, Brenner's tumor with borderline malignancy, or a malignant Brenner's tumor. And transitional cell carcinoma, non-Brenner's type. Directly, they have a transitional epithelium. Then we have epithelial and stromal tumor like adenosarcoma, means both of the element are present, with epithelial element as well as stromal element, or a mixed malignant mixed Mullerian tumor, MMMT tumor, malignant mixed Mullerian tumor. This is also a combination of the epithelial as well as the stromal one. Then we have sex cord tumor, which are granulosa cell tumor, fibroma, fibrothecoma, thecoma, Sartoli cell tumor, Leydig cell tumor, sex cord with yes, sex cord with annular tubules, ganandroblastoma, or steroid lipid cell tumor. Then we have germ cell tumor. So these tumors are arising from the sex cord. This is arising from the germ cells, which are teratomas, which are immature, mature, or solid cystic. Cystic majority, they are called as dermoid cyst, can happen anywhere in the body. Then we have monodermal tumor like struma uri or struma carcinoid. Then dysgerminoma, yolk sac tumor, or mixed germ cell. In mixed germ, we have more than one tumor at one time. For example, choriocarcinoma and uh, what you call dysgerminoma, or choriocarcinoma and yolk sac tumor. So it's a mixture of two tumors rather than one. Then malignant tumor with not otherwise specified. Sometimes the tumor are so undifferentiated that you are not able to label them. What are they? Either they are coming in this category or that category. So you put it in non-otherwise specified one. Then we have metastatic tumor like tumor coming from colonic mucosa or appendix or gastric or breast. So this is all the classification are. Now, if you see about the malignant potential and bilaterality is concerned, serous type, these are the tumor which shows the majority of malignancy, 45%. 60% are benign, 15% borderline, 25% are malignant. So this 25% becomes 45% of all these tumors, right? And as far as bilaterality concerned, the serous tumor, if they are bilateral, they are supposed to be either they are malignant, because the benign tumor, they are only 25% or borderline or 30%. Regarding mucinous, you just see only 5% they are malignant, and remaining 90-95% they are benign. And majority of them, they are not unilateral, they are mostly unilateral, 95%, only 5% they are bilateral. Endometrioid, as I said, that usually they don't have benign, borderline, or malignant. They are mostly malignant one. So they are 20% of the all ovarian tumor, and 40% they are bilateral. Clear cell carcinoma, they are for 6% malignant and 40% they are bilateral. Granulosa cell tumor, 5% they are malignant, and all by 5% they are bilateral. So granular cell also, the malignant potential are more in granular cell. Teratoma, Benign are 96%, malignant are 4%. They account for only 1% of all, and benign are probably 15% are bilateral. Metastatic one, 5% are metastatic, as we said, and more than 50% they are bilateral. So when there is bilateral tumor, we first think of either it is a metastatic or one. The others are 3%. Okay. We'll be starting with the non-neoplastic and functional cyst. So these are commonly seen in the ovary, like cystic follicle or follicular cyst. So these cystic follicle are usually multiple in number. The size are less than 2 centimeter, and they are filled with the clear serous fluid, and they are lined by gray glistening membrane, lined by granulosa cell mostly. So the large cyst, they exceed 2 centimeter, and when it exceed 2 centimeter, they are called follicular cyst. So if it is less than 2 centimeter, they are called cystic follicle, and if it is more than 2 centimeter, they are follicular cyst, and they may cause pelvic pain if they are larger in size. So they are lined by granulosa cell, as I said, and can be identified histologically if intraluminal pressure is not too great. For example, if the intraluminal pressure is more because of the fluid inside, they actually compress the epithelium, and sometimes you don't even see any epithelial lining, just a flat epithelium. So you may not see a granular cell. But if the pressure is not that much, so easily you can see that they are lined by granular cells. Now the other one is a luteal cyst. As the name says it arises from corpus luteum. Once the corpus luteum is formed, which is normally present in the ovary, the cysts are lined by rim of bright yellow tissue containing luteinized granular cells. So when the granular cell before ovulation, you know that they used to secrete estrogen, and when the ovulation take place, the oogote goes out, the same granular cell convert into luteinized granular cell. So luteinization occurs, and they now start secreting progesterone. So when the cyst is formed, they are now yellow in color. They occasionally rupture and cause peritoneal reaction in the surrounding area. Sometimes the combination of old hemorrhage and fibrosis may make their distinction from endometriotic cyst difficult, as we were discussing endometriotic cyst last time. And we have mentioned that there are three important things in endometriotic cyst. One is number one, endometrial gland. Number two is endometrial stroma, and the third one is hemorrhage. So if we said that one of the three things which are there, then we called it. So sometimes when these cysts they rupture or give hemorrhage and fibrosis, they may look like old endometriotic cyst, but you had to be very, very careful by saying that it is endometriotic cyst or a luteal cyst one. So these are the pictures. This is the first one which you see here. This is a large cyst, more than 2 centimeter. Now here, when you see uh, this is not a follicular cyst. This is another cyst. Probably it is looks to me as mucinous cyst adenoma or adenocarcinoma. But this one, which this person is handling between the finger and a thumb, and this one also, this is cystic follicle. This is follicular cyst, and you can see some transparent area. So because of the pressure effect, if you just cut it, you may not see granulosa cell here, just a flat line. On the right side, if you see on the right side, the upper one, this is also this one is the. Let me use the pen. So this one, this one. So these are cystic follicular cyst. Now, in a histological picture, if you see here, these cell, this one up till here, they are granulosa cell, which are lined by these cysts are lined by these cells. So you can easily see multi-layering of the granulosa cell, and inside you can see some of the cystic material or the serous material inside. But it's not that much. That's why you can easily appreciate the granulosa cell here. Okay, this is a follicular cyst. Now, if you go the other one, this is a gross picture, and uh, and you see this yellowish lining one you see with the naked eye. So this is actually a luteinized cyst, and this is a cystic area. This one, and it's lined by this yellowish material, which is luteinized one, luteinized granulosa cell. And this is a microscopic picture, and you can see a very it's a low power, but you can see that a small nuclei and abundant eosinophilic cytoplasm. So this is all luteinized granulosa cells or corpus luteal cyst. Now, coming to the other topic, which is polycystic ovarian ovaries or stromal hypertrichosis. Now, polycystic ovarian disease or PCOD, formerly they are called Steen-Leventhal syndrome. So, Steen-Leventhal syndrome they affects 3 to 6% of reproductive women. Here, the central pathologic abnormality is numerous cystic follicle or follicular cyst associated with the oligomenorrhea. Means either the menstrual cycle is bit increased in size. Means normally the female had 28 days of menses, so they might go up to 35, and there is scanty amount of bleeding in menses, so oligomenorrhea. So in a 1 year, probably instead of having 12 menses, the female may had only 10 or 9. So they have this is called oligomenorrhea. The woman with the this PCOD have persistent and evolution, obesity about 40%, hirsutism 50%, and they have virilism. So obesity 40%, hirsutism. What do you mean by hirsutism? Hirsutism means these female they have abnormal amount of hairs in their areas. For example, they might have mustaches, they might have small beard, or abnormal hairs in the chest also. And virilization means uh, there is a change in the voice, as we call it masculinization, and change in the voice pattern, or probably there'll be increase in the size of the clitoris. Okay. Now, morphology, these ovaries are usually twice the normal and have a smooth gray white outer cortex studded with the subcortical cyst ranging from zero point 0.5 to 1.5 centimeters. So, if you see the ovary, they will be larger in size, and on the cortical surface, multiple small cysts will be identified. Histologically, there is a thickened fibrotic superficial cortex beneath which are innumerable follicular cysts associated with hyperplasia of the theca interna, which is follicular hypertrichosis. Now, they say that this follicular hypothecosis is the main reason of this hirsutism and virilism, because these hypertrichosis area they start secreting androgen, and this androgen when they are secreted they start developing excessive amount of hairs. The corpus lutea are frequently but not invariably absent. Why? Because when there is no evolution, the corpus luteum is not, means this follicles cannot be converted into corpus luteum, so they are not been seen in these ovaries. So if you see multiple pictures here, this is a gross picture of the ovary, and in which you can see uh, one cyst, two, three, 4, 5. So these are different amount of cyst present in the cortical area. So this is a cortex, and this inside is medulla. So cortical area, you can see multiple different size cyst, and if you see or appreciate the outer area, this one is thickened, fibrotic, and this is the reason why. For example, if you have LH surge that much that the follicle is ruptured and the ova can come out, but because of this thick outer surface, this one. It does not allow ova to go out. It remains inside. And this inside, the follicle cannot change into corpus luteum. So there are multiple picture I have shown, and in each of them you can see multiple cysts here, and uh, and inside this is hyperthecosis, thick whitish area here. So in between this area, this is hyperthecosis, and they start secreting androgen rather than estrogen or female hormones. So this is the reason why it reacts like that. Okay. So this is all about this one. Now we are coming to the surface neoplastic cysts. So tumor of the surface mullerian epithelium, and this is the topic which we are going to complete today. The germ cells and sex cord stroma we will be discussing tomorrow. So there are three major histological types based on the differentiation of the neoplastic epithelium. So the most common type is serous, mucinous, and endometrioid tumor. Serous, mucinous, and endometrioid among these one. Now they also have classified the extent of the epithelial proliferation is associated with biological behavior of this tumor. For example, number one, benign. So the cyst will be benign and a minimal epithelial proliferation. Borderline, here we have a moderate epithelial proliferation, and malignant, marked epithelial proliferation with stromal invasion. Now it is very important point you should understand. The difference between borderline and malignant is, in borderline, you have only moderate epithelial proliferation. You may have atypia, but you don't have stromal invasion. This is a main characteristic feature of malignancy. If you see stromal invasion, then it is no more borderline. For calling it borderline, you should not have this stromal invasion in the ovary. Okay. So the benign tumor are often further classified based on the component of the tumor. For example, either it is cystic area, so they are called cyst adenomas, cystic areas and fibrous area, so they are called cyst adenofibroma because now fibrous areas are also there, or predominantly fibrous area, so you call it adenofibromas, right? Adenofibroma. So there will be no more, or there should be small cystic area, but majority are the fibrous tissue area. Again, the borderline tumor and the malignant tumor can also have a cystic component. And when the malignant, they are sometimes referred to as, if it is mucinous, you call it mucinous cyst adenocarcinoma. If it is serous, you call it serous cyst adenocarcinoma. So this is how you classify them accordingly. Now we are starting with the serous tumors. The common serous cystic neoplasm are the serous one, as we have seen, and they are lined by tall columnar ciliated and non-ciliated cells and are filled with clear fluid. As the name says, serous. So we have a clear fluid filled these cysts. This is how you differentiate. And if you cut it, you see these cysts are lined by tall columnar ciliated if there is less amount of pressure effect. But if the serous fluid is more, because of the pressure effect, probably the cilia are lost. But if you see it very carefully, you might see some of the cilia. Although the term serous appropriately describes the cystic fluid, it has become synonymous with the tubule-like epithelium in these tumors. So it has been seen, or they suggest probably the fallopian tube or fimbrial end, they might have, uh, by attaching with the ovary, and there is some tubal epithelium been started proliferating there, and they cause this tumor. Together with the benign borderline or malignant type accounts for about 30% of the ovarian tumor and just over 50% of ovarian epithelium. Okay, we have discussed already there. About 70% are benign and borderline, 30% are malignant. Benign and borderline tumor are more common between the age of 20 and 45. So this shows that if we are talking about malignant one, the age will be more than 50 if you're talking about the malignant one. So if the tumor arises in the younger age group, then they might be a benign or borderline. Now, molecular pathogenesis, if you talk about, uh, there is a difference, main difference, and we will be discussing. One is the risk factor for malignant serous tumor are nulliparity, number one, family history, and heritable mutation play a role in the development of the tumor. They say that there is a higher frequency of carcinoma in women with low parity. What do you mean by low parity? Means less amount of children if the female is married. And even if she is unmarried, again, because she is unmarried, no children, so she had more frequency of developing serous tumor. Gonadal dysgenesis, another one in children, is associated with high risk of ovarian tumor. So in children, if they have some problem in gonads, so they may cause this serous tumors. Women 40 to 59 years of age who has taken oral contraceptive or undergone tubal ligation, they have a reduced risk of developing ovarian cancer. So this is a plus point for the woman who has taken oral contraceptives. Now they have also seen that BRCA1 mutation occurs in about 5% of the patients younger than 70 years. But BRCA1 and BRCA2 mutation in 20% and 60% by the age of 70. So both BRCA1 and BRCA2 will be present when the patient is more than 70 years. If it is less than 70 years, you can only see BRCA1, which is present only in 5%. Now, they say that serous ovarian carcinoma can be divided into two main groups. When we were students, there were three groups, mild, moderate, and severe type of carcinoma. Now they have actually are well differentiated, moderately differentiated, and poorly differentiated. Now, according to the new books, they have just converted low grade and high grade too. In low grade, all those which are well differentiated comes under low grade. In high grade, all the moderately and poorly differentiated carcinoma, they come under the heading of high grade. So they have divided these in two major groups. Now they have seen that the low grade tumors arising from serous borderline tumor have a mutation in a KRAS and BRAF, KRAS and BRAF, with only rarely mutation of P53. Means if you are talking about low grade tumors, you might see a mutation of KRAS and BRAF. Now, on the other hand, in contrast, if there is high grade tumors, there is a high frequency of mutation of P53. So in high grade tumors, you can see a mutation of P53 and they can lack mutation of KRAS and BRAF. Almost all reported cases of ovarian carcinoma arising in a woman with BRCA1 and BRCA2 mutation are high grade serous carcinoma. And they have also P53 mutation. So P53 mutation, BRCA1 and BRCA2, they are all involved in high grade tumors. Now, benign tumor typically present with smooth glistening cyst wall with no epithelial thickening or with small papillary projection. So if you are talking about the benign cyst will be small. The outer surface will be smooth, glistening, shining, and I'll show you how it looks like. Bilaterality is common, occurring in only 20% of benign serous cystadenoma, 30% in serous borderline tumors, and about 66% in serous carcinoma. So if serous tumor are bilateral, you will think first of carcinoma because 66% of carcinoma, serous tumors are carcinomas. A significant portion of both serous borderline tumor and malignant serous tumors involve the surface of the ovary. So when you handle the ovary and you see a small, glistening, shining ovarian tissue, you will say probably it's benign. But if you are handling a gross ovary after operation and you see some thick areas, irregular areas, not shining one, you will think either it's borderline or malignant. The histological examination of the cyst are filled by lined by columnar epithelium, which has abundant cilia in benign tumor, and the microscopic papillae may be formed. So if you see uh, in benign one, you can see a papillary processes there. And in benign one, you can easily appreciate that there are one or two papillae in a near vicinity. But in a serous borderline tumors exhibit increased complexity, means there are large number of papillaries here of the stromal papillae, and there will be stratification of the epithelium. So in a benign serous cyst, there will be a single line of epithelium. So if you are asked to draw, you can see that this is a single line of tall column epithelium, right? Like this one. And there will be cilia on the top. Each of the epithelium will be having cilia in serous cyst, right? But and nuclear will be basally placed like this one. And they will be small, no hyperchromasia and atypia. But in borderline tumors, you have complexity, not like this one. So there will be multiple papillary processes, and there will be stratification. Means now, if you draw like that, you will not be having only single line of epithelium like this, but you can have even more epithelium, one over the other one. So this is called stratification. And the nuclei will not be very small one, but they can be irregular in size if it is borderline. But the only difference between borderline and malignant, as I've already mentioned, for example, this is stroma, so the basement membrane will be totally intact and the tumor will not be infiltrating into the stroma. The individual tumor cells in high-grade carcinomas display marked cellular atypia, pleomorphism, atypical mitosis, and multinucleation. The cell may even become so undifferentiated that the serous features are no longer recognizable. You cannot say, you will not see a cilia, and sometimes you cannot be even identify it's a columnar epithelium. I will show you. Concentric calcification, which is called sumoma body, characterize serous tumors, but they are not specific for that. So majority of the time we have seen a sumoma body. And what is sumoma body? Sumoma bodies basically show a dystrophic calcification or a necrotic tissue. So, and they form a rounded structure, and I'll show you how it looks like. So these are the feature actually of the serous cell. You will not see sumoma body in mucinous carcinoma or in any other one, ovarian tumor. So this is specifically seen in the serous tumor. The ovarian serous tumor, both low and high grade, have a propensity to spread to the peritoneal surface or omentum and are commonly associated with the presence of ascites. So as long as they are present in the ovary, the prognosis is good, and it is either stage 1 and grade 1 or grade 2. But if it has gone beyond the ovary and it has involved the peritoneal cavity, then straight away it is stage 4. So the prognosis of those patients are not good. As with the other tumor, the extent and spread outside the ovary determine the stage. As I mentioned, these findings are associated with rapid clinical deterioration. The patient will come down. 5-year survival rate, for survival rate tremendously come down. Consequently, careful pathological classification of the tumor, even if it has extended to peritoneum, is relatively both good for prognosis and selection for the therapy. So what we do is, when we receive the specimen, we see it very carefully that and we also ask the surgeon to send us the ascitic fluid. So we do the cytology for the ascitic fluid, as well as we see the ovarian tissue, and we grade it according to what we see the uh, the the cells. And when we see the cytology, and if it is cytology is negative, we just call it that uh, either it's grade 1, low grade or high grade, but there is no extension to the peritoneal cavity, so the grade will be either 1 or 2, not more. But the stage, and when it extends towards the what you call peritoneum, then straight away it is stage 4. The 5-year survival rate for borderline malignant tumors confined within the ovarian mass is respectively 100 or 70. For example, if it is borderline, it is 100%, 5 years. If it is malignant, it is 70% when it is confined to the ovary. But 5-year survival rate of the same tumor involving peritoneum, 90% for borderline and 25% for malignant. Okay, clear? So you just see how much drop occur when it goes towards the peritoneum. So this is a picture of patient, and this patient is having ovarian cyst adenocarcinoma. By looking at, you cannot say whether it is a mucinous tumor or it's a serious tumor, but usually you see a big abdomen like this one. Why? Because uh, as a clinician, I would probably say that this patient will be having extensive ascites, and she might be having a big tumor. So by having such a big abdomen, I will think of a malignancy. Now, this is a benign serous cyst, and as I was mentioning, the outer surface is very smooth, shining, glistening one. Both, if you see here, and if you cut it and you see, these are the papillary processes. So this is one papillary process. This is the other one. So you can see and demarcate one. These are all tall columnar epithelium. These are all cells, and they are single lined. And if you carefully see, you can see a cilia here. These are all cilia, right? So tall columnar ciliated epithelium, and definitely this is a serous fluid which has been drawn away when you cut the ovary. The serous fluid or a watery fluid is not no more there, but you can see some of the glimpses here, and you can see a core. This is a core, fibrovascular core forming a papillary, but uh, the histology of these cells or nuclei are very benign. There is no pleomorphism or hyperchromasia. The nuclei are basally placed, no stratification seen, no atypia. Now coming to this one, now you can see and appreciate. Now this ovary outside, it's not smooth, it's not glistening. They are irregular in shape. And you see this papillary processes in a gross appearance. This is called a complex structure. This is whole complex area. If you do histology, this is a basement membrane. This one is a basement membrane. So you have appreciated that none of the tumor cell are present in this area. So, and these are a complex, I can point out this one. This is all complex area. These are all papillary processes which is going up. And if you see, you might see cellular pleomorphism here, this one. It's not a normal looking uh, columnar epithelium, which you have seen in a benign serous type, right? Okay. Now, if you see here, it's a malignant. It's a papillary cyst adenocarcinoma. So if you see this gross picture, you can see multiple papillary processes, and they are all complex areas of a papillary processes. If you cut it and see under microscope, these are the lining epithelium. This is a basement membrane here. And if you see these cells, the nuclei showing pleomorphism, hyperchromasia, right? Irregular shape. Stratification means it is almost climbing over one another, right? It's not a single liner one. The nuclei are not basally placed. Even you can see multiple mitosis, for example, this one, mitosis, this one. So multiple mitosis can be identified. And the important thing is that this is actually the cells they have invaded into the stroma, ovarian stroma. So when you see a clear-cut invasion into the stroma, then it is very easy to see invasion in a serous type, and it is really difficult to see invasion in a mucinous type. Now, coming to the third picture here, this is called samoma body, right? This is samoma body. This is basically a calcification on a necrotic, a dystrophic calcification. And these cells you can see in a higher power that they show all the feature of malignancy, pleomorphism, hyperchromasia. You can see mitotic figures here, here, and they are also invading into the stroma here, right? This is samoma body. And what is samoma body? When you have a papillary processes, for example, these are papillaries. I hope you can see my fingers. And for example, one of the papillary, because they are fast going tumors. So what happened that the blood supply cannot cope up with the fast development of the papillaries. So on the tip, what happens? There is less amount of blood supply, and the tip of the papillary start doing necrosis. And when there is necrosis, then calcification starts developing on it, which is called dystrophic calcification. And when you cut it in such a way through while cutting the microscopic slide, then you get this type of concretion in between. This is called samoma body, and this is a peculiar identification of serous tumor. You will not see this thing in mucinous tumor. You will not see in this thing in an endometrioid tumor, clear cell tumor, or whatever. This is a peculiarity for a serous cyst adenocarcinoma. So there are also other tumors of the body which can show a serous one. So not only the ovary, but there are also the other one. Okay, this was all about the serous tumor. Do you have any question regarding this one? Can I go for the mucinous one?
Yes,
No,
doctor.
no, we can move, right? Okay. So whatever questions you can ask me at the end, and I'll go back, right? If you have. So the second one is a mucinous tumor. As I said, mucinous tumor are less common than the serous one, accounting only for 30% of the total neoplasm. They occur principally in the middle age life and are rare before puberty or after menopause. So we have a specific age group. Means you cannot have mucinous tumor before the age of 20, and you don't have mucinous tumor after the age of 65, 70. So in between, you can have that. 80% of the are benign or borderline, only 15% are malignant. In the serous one, it is 45% which are showing malignant, more than 50% rather, in all ovarian tumors. Primary ovarian mucinous carcinoma are relatively uncommon, primary, and account for only fewer than 5% of the ovarian cancers. Now, molecular, just think of the serous one where the risk factors are nulliparity or familial history. Here, the risk factor is smoking. In mucinous adenocarcinoma, the risk factor is smoking. So it is not like in the serous tumor. The other one is consistent alteration that has been identified is a mutation of KRAS proton cogene. So KRAS proton cogene, smoking. So these actually causes the risk factor of this serous tumor, mucinous tumor. Now, mutation of KRAS are common in a benign mucinous cystadenoma, 55%. They are mucinous borderline tumor in 75% to 86%, and a primary mucinous carcinoma, it's 85% that you see a mutation in KRAS. Now, about 5% of the primary mucinous adenomas and mucinous cyst endocarcinomas are bilateral, means majority are unilateral, only one side, but only 5% you see bilaterality. So when you see bilateral mucinous, first thing come in your mind is you are dealing with the malignant one. The mucinous tumor tend to produce large amount of masses. Some has been recorded with the age of 25 kg. So you just imagine how big this tumor can be. And as the name says, mucinous means you have excessive amount of mucin secretion in the center. In a serous one, it was fluidy secretion, watery secretion. It in mucinous one, it is a mucinous secretion. So this is a clear-cut one difference. Uh, they appear grossly as multiloculated, means multiple cystic spaces filled with sticky, gelatinous fluid rich in glycoprotein. So they are a sticky material which is present inside the cyst. That is why they are called mucinous cyst adenocarcinoma. The histological examination, benign mucinous tumor are characterized by lining of tall column epithelium with apical mucin and absence of the cilia. So this is one of the characteristic finding between these two difference, that in the serous one, you have a cilia on the top if you're talking about the benign and borderline. But here in mucinous one, even it is benign, you will not see any cilia. Yes, the other thing which you can see is the apical mucin. Apical mucin can be seen. I will show you how this apical mucin will look like. Now, cyst adenocarcinoma contained area of solid growth and a conspicuous epithelial atypia, stratification, loss of gland architecture, and necrosis. So this is important in malignancy. So if you see stratification, if you see cellular atypia, loss of gland, and necrosis, you will think of cyst adenocarcinoma, because both borderline and malignant mucinous cyst adenocarcinoma form complex gland. And you know what is complexity means? A large amount of papillaries, gland in the stroma. Documentation of clear-cut stromal invasion, which is easily ascertained in serous, is difficult here. Now, what happened that as I have shown you the picture in mucinous serous cyst adenocarcinoma, in the stroma, you can see easily a group of malignant cell. But in borderline or in malignant uh, mucinous adenocarcinoma, it is really, really difficult for you to see because of the large amount of complex areas. Approximate 10-year survival rate of stage 1 non-invasive intraepithelial carcinoma and a frank invasive malignant tumor are greater than 95 and 90% respectively. 95 and 90% respectively. So you can see the difference between these two. Mucinous carcinoma have had spread beyond the ovary and are usually fatal, but the previously stated these tumors are uncommon, right? As mucinous cyst adenocarcinoma is less common than the serous one, so only serous tumors are uh, dangerous because they are more becoming malignant. So this is another picture of a patient. You can see a very large abdomen. This shows not only the ovarian size, but also it is filled with ascites. And if you just tap the fluid, you can see a malignant cell there. Now, this is the ovary, benign mucinous cyst adenoma. Here you can see that the outer surface is not that much glistening as you see in the serous type. There is some irregular areas and thickened areas. So mucinous cyst, even if it is benign, it is not that much shining. Now this is actually the epithelium, which I said. Although we have normal looking epithelium, this is all tall columnar epithelium, right? And all nuclei are basally placed and they are all looking normal, right? Basally placed nucleum, but you don't see any cilia here. So this is actually a very diagnostic criteria of calling this thing mucin. Now this you see the watery mucinous secretion here, coloring as pink or blue, pinkish blue. These are all mucinous secretion, which when you cut the ovary, majority of it has been drained out, but some mucinous structures are strict here. So this is a pure benign mucinous cyst adenoma. Now to compare this one, apical one, I have kept the same picture of serous cyst adenoma here. Now you can see that these are the cilia here, although we have a tall column epithelium here also, but you cannot see these apical mucin which you see in a mucinous cyst. These are called apical mucin, which are continuously secreting mucin outside. There is no apical mucin here. So you can appreciate between this cell and this cell. Although we have tall columnar epithelium and basally placed nuclei here also, but and there are cilia and there is no cilia here. So this is also one of the diagnostic point of comparing serous cyst adenoma and mucinous cyst adenoma. Grossly, you can see mucin secreting outside, and in serous cysts, you see a watery fluid coming out. Okay. Now, this is a huge ovary you see coming out from the patient, probably the same patient which I had showed you before. So, by looking this much of size, the first thing I can think is probably we are dealing with malignancy. Now, this is called multiloculation. One cyst, the other cyst, the third cyst, the fourth cyst, the fifth cyst. And in the cyst, you can see this thing, these are all mucin, whitish color. They are all filled with mucin secretion. Although while cutting, some of the mucin has been drained, but still you can see some mucinous area here. Now, if you cut it, suppose if it is benign, it will look like this one. A single line epithelium, this one, a single liner with the basally placed nuclei and apical mucin, apical mucin. So this is a benign one. But if it is malignant, you can see this is called stratification. This is called stratification. Please don't miss this one. Normally, you have seen that it should be like this one, a single liner. But here, you have one epithelium, you have second epithelium, you have a third epithelium, this is fourth epithelium. So this is called stratification of the epithelium. The nuclei, which should be here only, basally placed, now they have shifted up and there are multiple variable size the nuclei showing pleomorphism, and you can see a lot of mitotic figure. For example, this one is mitosis. You can see this mitosis. You can see this mitosis. So you can see multiple mitoses, and stratification pleomorphism means irregular shaped nuclei, prominent nucleoli. You can see this prominent nucleoli here. So these are all feature of malignancy. But as I mentioned here, it is really difficult for you to see that it is invading into the stroma, right? As it is very easily been seen in the what you call the serous cyst adenocarcinoma, but mucinous cyst adenocarcinoma, it is really difficult to see. This is a gross picture of that big ovary, and probably it may weigh about 20 to 25 kilogram. Okay. Now, myxoma peritoni, as a name says, pseudomyxoma peritoni. What happened that uh, there is extensive mucinous ascites, cystic epithelial implants on the peritoneal surface, adhesion, and frequently mucinous tumor involving the ovary. So, if the same patient having mucinous cyst adenocarcinoma, some of the cells come out from the ovary and they form or droplets on the peritoneum, they form pseudomyxoma peritoni. And they will have adhesion, they will be having implantation, cystic area, and you can see extensive area of mucin there. This is called pseudomyxoma peritoni. Now, this pseudomyxoma is peritoni, if extensive, may result in intestinal obstruction and death. They can cause intestinal obstruction and the patient can die. Historically, it was thought that many cases of pseudomyxoma peritoni in women were due to the primary ovarian mucinous neoplasm. When we were students, it has been taught that when there is a mucinous tumor, they can involve peritoneum, and this pseudomyxoma peritoni is 100% because of the mucinous carcinoma. But now, recently, evidence point to the presence in most cases of the extra ovarian, usually appendiceal origin, the primary mucinous tumor with the secondary ovarian and the peritoneal spread. So how can we identify this, whether it's primary or secondary? The important thing is because of the majority of the primary mucinous tumor, they are unilateral. Bilateral presentation of the mucinous tumor always requires exclusion of a known ovarian origin. So what happened that if you see pseudomyxoma peritoni, and if you see that the ovary of both sides are involved, it's bilateral, then probably it is not a primary mucinous cyst adenocarcinoma. So you have to look for other areas, and the best area is appendix. So I think it's 2 or 3 times in my clinical life I have seen that when I see bilateral mucinous cyst adenocarcinoma, I went back to the surgeon and talked to him that please kindly see, do some ultrasound and something and see the appendix, or you open it up again and see probably the appendixes are good or not. When then he sent us the appendix, we see the same mucinous tumor, although the appendix was not so big as the ovaries are, because ovary has uh, a large area to expand, but appendix does not expand that much. So the size of the appendix was not that big, but we have seen the same amount of cells, the same amount of mucin uh, in the appendix. Probably that might have metastasized to the ovary, and then it has also involved the peritoneum. So if it is bilateral ovarian mucinous cyst adenocarcinoma, you had to look for the appendiceal origin. Okay, is it clear now? Okay, this is how it looks like. This is also called omental caking. So multiple small nodules are formed on the appendix. You see, this is called omentum. The whole omentum is been deposited by these small nodules, and you take the section, you see large amount of mucinous pool. Plus, you have also seen this lining epithelium. This is mucin secreting cells, and the nuclei are large hyperchromatic pleomorphism. You can see also the mitotic figures, right? So by this, you can say that it is either coming from ovary or somewhere else. If it is only unilateral, then probably definitely it is coming from the ovary. But if it is bilateral, then try to see probably the origin is somewhere else. And if you see appendix, and if the appendix is also showing the same tumor, then there is a possibility that the tumor, which is you are seeing here, pseudomyxoma peritoni, is actually coming from the appendix. Okay. Then endometrioid tumor, the benign endometrioid tumor called endometrioid endofibroma or borderline endometrioid tumor are uncommon. However, endometrial carcinoma account for about 20% of all ovarian cancer. As I mentioned, that yes, benign and malignant borderline are not seen in endometrioid. And why we call it endometrioid? Because the tumor cells look like endometrial cells. So they are called endometrioid, right? Like epithelioid. If you remember my lecture in POD, epithelioid cells, the macrophages look like epithelium. They called epithelioid cells. This is endometrioid tumor, which means this tumor is just looking like endometrium. So endometrioid tumor are distinguished from the serous or mucinous tumor by the presence of tubular gland bearing a close resemblance to benign or malignant endometrium. So the shape of the cells are just like endometrium. In fact, 15 to 30% of ovarian endometrioid carcinoma are accompanied by carcinoma of the endometrium and relatively good prognosis. Means that if you have ovarian endometrioid carcinoma, and if you go and see for the uterus, probably in 15 to 30% of the cases, you will see the uterus also involved with endometrioid carcinoma. Pathogenesis, about 15 to 20% of the cases with endometrioid carcinoma coexist with endometriosis. So endometriosis is also an important factor, although the origin can directly from the ovarian surface epithelium. can directly judge. But if you can even see some endometriosis in a near vicinity. The molecular study have found relatively frequent mutation in the P10 suppression gene, which you always see in endometriosis. So they have seen, or they have, and they have, you can have also KRAS mutation, beta catenin, and also microsatellite instability. But according to the researchers, they have seen that they're similar to the endometrioid carcinoma of the endometrium. P53 mutation are commonly seen in a poorly differentiated tumor. So if the tumor is poorly differentiated, you can see mutation of P53. So the endometrioid carcinoma associated with endometriosis, identical P10 mutation will be have been detected in both the carcinoma and endometriosis, suggesting that P10 mutation may precede the development of malignancy. For example, you have seen that in endometriosis there can be a P10 mutation, and slowly and gradually from endometriosis it has changed into endometrioid carcinoma. Morphology: in a gross appearance, endometrioid carcinoma presents as a combination of solid and cystic areas, similar to other cyst endocarcinomas. 40% involve both ovaries. Now here, the involvement of both ovaries are 40%. Such a bilaterality usually, though not always, imply extension of the neoplasm beyond the genital tract. So if both of the ovaries are involved, there is a possibility that maybe the tumor has extended from the ovary to some other parts. There are low-grade tumors that reveals glandular pattern bearing a strong resemblance of endometrial origin, and 5-year survival rate in stage 1 tumor is 75%. So the prognosis of this tumor is very good. So this is how it looks like. This is a gross picture of this is endometrioid carcinoma. You can see that there are cystic areas, there are solid areas, but not like serous carcinoma or mucinous carcinoma. You see some of serous secretion or mucinous one, but they are mostly small amount of fluid, which is not actually the serous or mucinous one. And if you do the sections, you can see a glandular structure, and each gland looks like the endometrium, right? And they have a similar feature of endometrioid carcinoma. And this is a basement membrane, and you can see that one of the glandular structure is present or invaded into the stroma. So it's an endometrioid carcinoma now. Okay. Now coming to clear cell endocarcinoma, these are not that much common. They are very uncommon. They are characterized by large epithelial cell with abundant clear cytoplasm, to similar to the hypersecretory gestational endometrium. This tumor sometimes occurs in association with endometriosis and endometrial carcinoma, which resemble clear cell carcinoma of the endometrium. So probably I think today's lecture of Dr. Imad, he must have mentioned about this clear cell carcinoma of the uterus. uh, in the solid neoplasm, the clear cells are arranged in sheets or tubules, and a cystic variety, the neoplastic cell line the spaces. 5-year survival rate is approximately 65% when the tumor are confined to the ovary, but if it is gone beyond the ovary, 5% survival rate is exceptional, means very low. Now, cyst adenofibroma, as the name says, cyst adenofibroma, so it's a benign tumor. It's a variant in which there is more pronounced proliferation of fibrous stroma. That's why we call it fibroma, that underlie the columnar lining epithelium. These benign tumors are usually small and multiloculated and have small papillary processes, and they do not become complicated or branching as they found in ordinary cystadenoma. Borderline lesions are atypia is rare, so we don't see any atypical thing, or they can spread anybody anywhere. So this is how it looks like: a small tumor, ovaries, and if you just cut it, this is all whitish in color because most of them they are fibromas. So fibrous tissue proliferation usually give a whitish color, And if you cut it, you see a papillary processes. For example, this one, these are papillary process, but just beneath the epithelium, this is a columnar epithelium. Just beneath the epithelium, you see this extensively proliferating fibrous tissue. So this is cyst adenofibroma. Coming to the Brenner's tumor, this is another one. It's not that much common as the other one. The Brenner's tumor are classified as adenofibromas in which epithelial component consists of nest of transitional epithelium. So let's go back. For example, if this same adenofibroma, and if you see uh, groups of cells here, transitional epithelium here, right? If you see a group of cells here, which are resembling transitional type, resembling lining of urinary bladder, you call it Brenner's tumor. Okay. So these neoplasm may be solid or cystic, are usually unilateral, approximately 90%, varying in size from 1 centimeter to 20 to 30 centimeter. The fibrostroma, resembling that of a normal ovary, is marked by sharply demarcated nest of epithelial cells resembling the urinary tract. So this is how it looks like. This is outer surface of the ovary. This is the inner cut surface, and in cut surface you can see these are the solid areas, and some cystic areas are also seen here, and some of the cystic areas are filled with mucin. So mucin is not regularly or very advancedly seen, but if you see here, these are all fibrous areas. These are these one these are fibrous tissue areas, and these actually are the nests of transitional epithelium in between. These are nests of transitional epithelium, and this is the same transitional epithelium which you see in a urinary bladder. Some of the glands show a mucin secreting epithelium, and they secrete this mucin, right? Not all. For example, in this one, you hardly see any mucus secreting cells, right? But they are mostly looking like a transitional epithelium. So these are called Brenner's tumor. So clinical course, we have discussed the clinical course on together. All the epithelial cell tumors behaves the similar way. All ovarian epithelial tumor produce most common lower abdominal pain and abdominal enlargement. It depends. For example, if it is benign, there is small enlargement of the abdomen, but if it is malignant borderline, the abdomen is hugely enlarged. Gastrointestinal complaint, urinary frequency, dysuria, pelvic pressure, and many other symptoms like progressive weakness, loss of weight loss, cachexia, characteristic of malignancy, will be seen here in these tumors. If the carcinoma extends through the capsule to the tumor and seeds to the peritoneal cavity, massive ascites will be identified, which is common. And if you do the ascitic fluid examination of the exfoliated cells, you will see exfoliated tumor cells in ascitic fluid. So all serosal surfaces are diffusely seeded by zero point 0.1 to zero point 0.5 centimeter nodule tumor. These surface implant rarely invade deeply into the underlying parenchyma. So as I showed you one picture there, they form an omental caking throughout the peritoneum. The renal lymph nodes are also enlarged secondarily, and there will be a metastasis found in the liver, lung, gastrointestinal tract, and elsewhere where it can go. So metastasis across the midline and involving the other ovary is seen in half of the cases. So many patient with first seen has a lesion no longer confined to the ovary. So usually in our part of the world, patients are so shy and they don't tell that we have a problem. But when the abdomen is increases large, then they come to the doctor, and by that time the tumor, if it is malignant, uh, may spread into different areas or into peritoneum. So the 5 or 10-year survival rate becomes come down. Specific biochemical markers for the tumor antigen or a tumor product the plasma of this patient are being sought. So as we see in prostate PSA, to sort out the prostate cancer, we are looking for ovarian tumor. So we have one marker which is CA125, which is high molecular weight glycoprotein present in the serum of 80% of the patient with a serous or endometrioid carcinoma. But this marker, as in PSA, it can be seen in inflammatory condition, right, which is non-neoplastic one, or in endometriosis. So CA125 can be more high, but we can see how much high it is, because in tumor this CA125 will be tremendously high, but in inflammatory condition it is low. So they are looking for some more, markers. So osteopontine, this is another marker which is expressed in a significantly high level of ovarian carcinoma of the patient. So may improve early detection. For example, if a person who had CA125 in the serum, and then they ask for osteopontine, which is also high, then definitely you will think more of a tumor site. These and other approaches may in future create more cost-effective, non-invasive approach of the ovarian screening. So this was all about the epithelial tumor, and inshallah tomorrow we will be discussing the germ cells and the sex cord one. So do you have any question? You can please kindly ask from the student. Hello. If you ask, I can go back to the slide which you want to ask any question. So hopefully there is no question, right?